Thank you, Crystal, and good afternoon, everyone. Welcome to the webinar. I'm thrilled that you could join us and really happy that you share our interest in our topic today, Health System-Wide Sustainable Peer Program Best Practice. And today's webinar is the third in a series that was developed by collaborators located in SAMHSA Region 3. Our states include Pennsylvania, Maryland, DC, Delaware, Virginia, and West Virginia. And the ideas for the webinars bubbled up from three main collaboration groups that we have. One is the Opioid Overdose Prevention Group. The second is the Behavioral Health Workforce Group. And the third is the Medical Schools Collaboration Group. We encourage your questions through the webinar, even though you can't see us and it's not as interactive as we'd like it to be. We really love your questions, and we've had quite a few very helpful to us, and hopefully with the answers going back to the field, helpful to you. If we don't get to all the questions, you'll get customized, individualized answers from the faculty today. And Crystal, go ahead, and I have a few slides here for you today. I wanted you to basically see that this is one of a series and understand how all these pieces fit together, because we're really hoping that as many of you as possible go back and review the archives for webinars 1 and 2. And also learn that there are many excellent resources available on our topic, many from SAMHSA, also from other organizations, and we just want to make you aware of those. So, Crystal, are you going to scroll through these for me?
Yes, I will.
Okay. I think we can do that now. And there we go. So there are hundreds of SAMHSA resources on our website that are free and downloadable. Some you can request to have sent to you. Just go ahead and scroll through these. These are just a few examples, and I'm not going to take the time to go over them because the webinar does not allow us enough time for that. But I also want to just let you know that if you want to have your own webinar or collaborate with us in Region 3 on future projects like this, we would love to do so. And based on the polling today, I think there's a wide open opportunity for us to talk more about screening, brief intervention, referral, or treatment, as well as more discussion about peers. So just stop here for 1 second. So I wanted to make sure, go back up. I just want to make sure that you understand who our other faculty are. Dr. Mayman was actually the person who kept asking about how to start a peer pilot in the emergency room where she is located, which triggered other discussions and led to the whole series. Brian Haller was her co-faculty member on the first webinar, and he talked about his wonderful program in Maryland. Then on the second webinar, Dr. Ken Martz from Pennsylvania Department of Drug and Alcohol Programs talked about the warm handoff model that they've developed there, and many important success factors related to having warm handoffs work. His fellow faculty member was Deputy Commissioner Kim Walsh from West Virginia, where they developed a 24/7 hotline that directly connects people immediately through a human answering the phone by the second ring. And other states are following suit and coming up with similar hotlines, which we think is just terrific, because getting people into treatment and recovery is really all of our goal. And then today, we're just thrilled to have Mark and Peter, and sure you're going to have questions and feedback for them as well. So I think without further ado, we'll go ahead and get started. And thank you all again. Thanks, Crystal.
Thank you, Dr. Bennett. I will now hand things over to Mark DeWitt Lanyon and Peter Booras.
Okay, good afternoon. My name is Mark Lanyon.
I'm Peter Booras.
And We just wanted to acknowledge Dr. Terry Horton. Some of you may have heard of him, have met him, have interacted with him. He's the visionary behind Project Engage and the creator of Project Engage. Today, we are acting as his ambassadors to present this webinar. So the learning objectives, we want to help you understand how you can develop a peer-run program within your institution, how best to work with your leadership team to have them embrace this concept, and also learn how engagement specialists can provide a positive outcome for hospital-based patients and with the medical staff, actually the whole interdisciplinary healthcare team working with them. So a need was identified in the Christiana Care health system, and in July of 2007, Dr. Terry Horton came to Christiana Care after being the medical director of Phoenix House for a number of years. The very first day and the very first patient he saw was a patient who had recovered from pneumonia and was being discharged. When Dr. Horton went to examine her, it became obvious to Dr. Horton that the patient was nodding, probably from heroin. He looked over at the fiancée, who was also nodding. At that point, Dr. Horton turned to the nurse, and the nurse asked, "What are we going to do?" And Dr. Horton said, "Well, at this point, there's nothing we really can do but discharge her." And Dr. Horton said that was kind of his aha moment when he realized something really had to be done to address this issue within the hospital. And Dr. Horton, up at the Phoenix House, had worked with peer counselors for a number of years and thought, hey, let's have a peer counselor worker in the hospital. So he reached out to Brandywine Counseling, and they were agreeable to bring in a peer counselor named Bobby into the hospital. And as Dr. Horton likes to say, we're off and running. So Dr. Horton, throughout this whole time, has been our champion for Project Engage. So we developed a collaboration between Christiana Care Health System and Brandywine Counseling and Community Services. And as you can read, Christiana Care Health System is one of the largest healthcare providers in the Mid-Atlantic region, and Brandywine Counseling and Community Services is a major provider of addiction treatment in Delaware. Just to give you kind of a picture of Christiana Care Health System, we have two hospitals. One's located in Wilmington and the other in Christiana, which is right by Newark, Delaware. There's a total of 1,100 beds, and on average we get a little over 150,000 ER visits annually and almost 53,000 admissions. And this is based on the 2011 data. And I think for some of you, you understand and realize and have experienced how hospitals tend to aggregate the highly disordered. And substance use disorders, individuals that have substance use disorders, they're common and they can sometimes be a challenge. And they tend to influence the outcomes, and a lot of times the outcomes are poor because of the person who's using substance uses. They also, individuals with substance use disorders, there tends to be an overutilization of the hospital resources. There can be safety concerns, which we'll talk about a little bit more further on in the webinar, and poor staff morale. And by that, what we mean is, especially if you're working in the ED and you see people coming in and out, and you have to wonder, is this person ever going to get well? And so that can really be challenging for the staff working there as well as inpatient. So it's estimated that individuals with substance use disorders who frequently visit the ED, they result in about 9 visits a year with an average cost of about $13,000 per patient. And also, individuals with substance use disorders average about 1.3 inpatient hospital admissions. And that can charges about $45,000 per patient. And we understand, depending on where your institution is located, it may be a little bit more, it may be less. But the bottom line is, individuals with substance use disorders do have a financial negative impact on your health system. You're going to see as we go through the webinar, there's key components. That's what we're calling it. Key components for a successful peer program. And when we say peer, what we're talking about are people who are in recovery from substance use disorders. We have found that utilizing peers in recovery from substance use disorders, that helps break down the resistance from hospital patients. I can think of one example. Peter and I was shadowing him, we went to see a patient. The doctor had just walked out of the room. So Peter was like, so, I'm Peter, Project Engage. You wanted to talk, what's going on? And he said, I have a little bit of an issue with alcohol. Peter said, well, the doctor just left. What did you tell the doctor? And he said, oh, I told him I might have 1 or 2 beers a week. So Peter said, well, what are you really doing? Because Peter had shared he was a recovering alcoholic. So that made the patient feel more comfortable. And he said, well, actually, it's more like 2, 3, sometimes 4 6-packs a day. And so that he was able to break down the resistance. So the other thing engagement specialists do, and we're going to explain this in greater detail, is we help get interested patients into community-based treatment. And our engagement specialists, they work in the emergency department, inpatient, and also out in the community.
An engagement specialist, which is what I am. We are peers in recovery from substance use disorders. Our function in the hospital is to support the interdisciplinary healthcare team in taking care of the patient. We collaborate with everyone, including social work, to get the best outcomes for our patients. The way I look at it is the threshold to a patient's room is kind of a crossing point for me. When I cross over into a patient's room, I'm a peer. I'm going to disclose my experience, going to discuss my use, I might discuss my recovery, depending on what the patient may need or what they're offering me. But I'm all about them to see what it is that we can do for them. When I cross back over that threshold, now I'm a professional member of the multidisciplinary team, there to help the medical staff, the social work staff, everyone come to the best decision-making process we can for the patient's ongoing care. We have become expert in available addiction treatment. We do use evidence-based practices, and we're skilled in patient placement.
And Peter, just you said about the evidence-based clinical practices, one of which is motivational interviewing. So do you want to talk a little bit about that?
Motivational interviewing, in the way we practice it, it is mostly an attitude rather than a series of techniques. We take the attitude that we are a consultant, a collaborator with the patient. We meet them where they are completely. Whatever they're ready to accept or whatever they're ready to discuss or whatever they're ready to change, we're there to help them with that. We accept and work with whatever ambivalence they may have. We may try to nudge them a little bit, a little bit through the stages of change, but we recognize we're just there for a moment in their life during that admission. But we do support their own ability, their self-efficacy. If for no other way, we can say, if I can do it, you can do it. And we will support their plan, even if we think that they maybe need more extensive help. We're going to work with what they give us. And we will even make concrete steps to work on a plan where, we might not think it's going to work for a patient's recovery, but it may work for their discovery that they need actual care beyond the hospital. For example, I saw a patient several times during one of his stays, and he was drinking something on the order of a quart of vodka a day, along with a case of 16-ounce beers. We talked a lot. He became open to understanding that he had a problem. We worked on some ideas, and then the very last day when I walked in, I asked him, so what do you think? What do you think we could do about this? And he said, you don't have to worry about it, Pete. I've got a plan. I'm like, great. What are we going to do? He said, no more hard liquor. I'm just going to stick with the beer. I said, okay. All right. That's a plan. That's a plan. How do you think you're going to do that? And we talked about that. We expanded on it. Now, it was probably about 6 or 8 weeks later, he did call me back and said, you know what? I can't cut down. I can't just stick to my resolve to drink beer, and my life is still spiraling out of control. What do you think now? And I think because I was open to his plan and I wasn't, part of the background noise to him of people telling him what to do and telling him that he had a problem and telling him how to fix it, he was more open to call me. There's a significance to having us be in the hospital, a historical significance. It's worked throughout what has worked in substance abuse treatment. It all started with Alcoholics Anonymous, which the origin of which, as everyone knows, was two alcoholics helping each other, and that identification factor was very powerful through the disclosure. This makes patients feel more at ease. They're not judged. This can actually spread to the whole healthcare team as well, because we're part of they do see us as part of their healthcare team, and now everyone seems to be much more open to them. They feel like their needs are really being addressed. Through that comfortability that sometimes we are able to get with the patients, we can get a much more accurate history, not only of their substance use, but a lot of their health-related changes, health-related information as well. Peers actually are commonly used for throughout all various disciplines, especially in diseases like diabetes and heart disease when lifestyle changes are required. Mental health uses peers. Other mentoring programs use peers. It's novel, but it's not really novel. We know that this template works. When we're in the hospital as peers, we are also an example, not only to the patients that recovery is possible, but to the medical staff who maybe don't have as good a grasp on the idea that recovery is possible as we would like. We are an example of that, and we openly share and disclose our stories with anyone in the hospital who asks or would benefit from it. We're a support for the interdisciplinary team. We're a tool that they can use where previously they may not have had one to help people get into treatment or to get help for their substance use disorders. As I said, we may elicit more accurate and detailed history. Very often what happens, our patients will be having symptoms that are confounding the medical team, and once they tell us the extent and nature of their substance use, it becomes obvious that they're having withdrawal symptoms, for example. In that way, we're a huge support to the medical team. We offer insight into the patient's point of view. A lot of times, we actually have been the man in the bed a lot of the times. We understand the subjective experience of an addict through our own personal experience, and we can share that with members of the care team, which can, in a lot of cases, help explain the behavior of the patient, the less than helpful behaviors, the hard to control, whatever it may be. And once we kind of explain perhaps what that point of view is of the man in the bed, it can lead to greater empathy and at least clarity to the staff. We have been trained on all aspects of addiction, so we can serve as go-to people throughout the hospital as authorities on addiction and its treatment. We do speak the language of addiction, and because we become trusted consultants to the patients, we sometimes act as translators, sort of, between the staff and the patient, and not just for the purposes of substance use, but also for their care. We can help tie their health condition, treatment, and substance use together for the patient for their benefit and to the benefit of the interdisciplinary team. One of the main things that we are involved in is discharge planning and assisting with that. We take into consideration, obviously, what their medical situations are going to be, what their follow-up appointments will be, what perhaps home health care or physical therapy, occupational therapy, whatever they have coming. We will dovetail their substance abuse treatment into that to make sure that we're taking care of the whole person. Treatment resources obviously are an area which we have to become very knowledgeable as consultants in substance use treatment. We have relationships with referral resources. We've become astute at the facility's intake procedures. We do have a working knowledge of insurance coverage and how it works. We gather all the information for pre-authorizations. We have relationships with insurance case managers who follow their clients in the community. And besides the training that we receive on-the-job training through the experience of just working here. But keep in mind, as peers, we also have personal experience with all the different types of treatment and recovery models. A lot of us have been to inpatient and outpatient treatment at different facilities at different times. A lot of us use 12-step groups in our own recovery. All of this can be very helpful to a patient who may be willing to accept that they need some further care or substance use treatment, but they don't understand it or they're afraid of it. They have perceived barriers. They have misconceptions. We can address that in a very, very credible way, having been through it ourselves. All of that helps us ensure better outcomes.
So another key component for a successful peer program, we like to say that the project engagement specialists are experientially credentialed. Now, some of the engagement specialists, they have, one has for MSW and a CADC, but we've encouraged and they're required, all the people coming on board have to get their CPRS, which is a Certified Peer Recovery Specialist. So at least they begin to become credentialed, and we encourage people to move forward. One fellow just got his bachelor's, he's begun his master's program, because we view the engagement specialists as professionals, and so we want them to go forward with their education in any way possible. And the mission of Project Engage, we want to help Christiana Care health system patients return to healthy, productive lives, because by getting them on the road to recovery. And that's why, as engagement specialists, we serve as care coordinators, and we can provide recovery support to assist patients in accessing care. And they're just saying, no, I'll go once a week to talk to somebody. I can think of this one older gentleman, had many, many years of alcohol use. His wife had told him, unless you get treatment, you will not come back into the home. The one engagement specialist kept talking with him and saying, I understand, you probably just want to go home, but your wife isn't letting you. What can we do to deal with that? So he finally agreed to go inpatient, and we saw him off to the van that took him to the inpatient facility. So having that experience is invaluable, and they're able to translate that into a working method. So here's like a little timeline of what happened, how Project Engage grew. I told you earlier, Dr. Terry Horton came to Christiana in 2007. Realized, oh my gosh, we really need to do something. So phase one, we call it the Wilmington Hospital pilot. That's when Bobby came on board. And then we're going to go in a little more detail, phase 1, 2, 3, and 4. But what I really want to point out is, look, we went from 2008 all the way to 2012 before phase 2 began. Peter's going to talk about that in more detail, what went on during those 4 years. But I know sometimes people are like, wow, I want to get this program, and just instantly we're going to have social workers and engagement specialists, and we're going to do all this great work. It could happen that way, but sometimes some planning needs to take place. So let's look at phase 1.
Phase one was at Wilmington Hospital, the smaller of the two Christiana Care hospitals. It ran from 2008 to 2011 using a gentleman named Bobby Dillard, a recovering addict, and a certified prevention specialist from Brandywine Counseling. He was embedded, he worked only in the hospital. He was up here himself, obviously, and he used motivational interviewing techniques and attitude to achieve his goals with his patients. He used an outreach model. He actually drove patients from the hospital to their treatment appointments. He used a lot of faith-based and non-traditional treatment options as needed. He was basically allied with the social workers in the hospital, the floor social workers, who would find patients interested for him and refer Bobby to go see them. He worked the entire campus. He worked the inpatient units, the outpatient services, the emergency department. He even went across the street to the annex where we do community medicine. Bobby left, and I took over his position. What basically happened was Bobby retired early in 2011, and the program was at a crossroads, not because Bobby left, but because growth was about to happen, and they wanted to prepare for that. When I was hired, I was tasked with professionalizing, systemizing, and improving on this very successful start that had already happened. They wanted me to use a wider variety of resources, more traditional facilities, gain familiarity with insurance, actually perfect a method of engagement with the patients, kind of document and write a manual about how to do this with training for training purposes and to guide the future specialists, develop a resource guide of places that I've learned that we can use and how to use them. I kind of stumbling around at that point, it was an incubator for ideas. I identified the need to actually see the patient's medical record. Dr. Horton and I would commonly walk down the hallway and talk about how are things going, and one or the other of us would suggest an enhancement, and to his credit, he could make those enhancements happen very, very quickly, such as we were a social work function in the beginning, and it would take a day or two before we could get a referral from a patient just because of the processes. That was probably taking too long in our eyes, so we identified that the nurse might be a better resource for that, and that's how we actually started to roll out the program to proceed, having it be more of a nursing function than a social work function, although we take referrals from everybody. And I also saw that actually connecting people with care was very complicated and time-consuming and kept me away from actually seeing patients. So the need for a dedicated social worker was identified during this period. After we got to that point, 2 new specialists were hired, and we rolled out using the lessons learned at Wilmington Hospital into the larger hospital at Christiana in Newark, Delaware. We formally rolled out with all of the bells and whistles that we had developed up until that point. And we continued to grow. The need continues even to this day to grow. Christiana was phased in floor by floor as the demand was identified, which was immediate. And by way of example, Wilmington's yearly volume now is nearly what the previous iteration, what Bobby actually saw the whole time he was here. We'll actually see that in a year at this point. Based on the successful rollout to Christiana and our small foray into the emergency department at Wilmington, it was identified, the emergency department requested to have their own dedicated specialists. Wilmington kind of, had always done it, but had done it in a specific way, acting as if they were just like inpatients. They had to be referred by the medical staff or the social worker in the emergency department, and then they would call. Not very often, but it would happen. The new program, the engagement specialists were freed up to seek out their own patients by looking at the tracking system, looking in the charts to see who likely candidates may be. So we kind of call it a cold call. They will walk in and develop their own patients without a referral. And at this point, we have 3 inpatient specialists, 3 emergency department specialists, and 2 dedicated social workers. And the engagements that we do in the emergency room now are almost all self-developed by the specialists themselves. But there's still more need.
So another key component for a successful peer program is to have a dedicated social worker. And as Peter said, we have 1 dedicated social worker at Wilmington and 1 at Christiana. And
the need for a social worker came in the early days, even when the volume was lower, because substance abuse referrals can take hours and require many calls and many follow-ups, both to secure a treatment bed and to get the necessary insurance pre-authorization. I myself was taxed at developing and growing the program. I wanted to see patients. The floor social workers had all they could handle with their duties as well and didn't feel like getting into substance abuse treatment from the hospital was as achievable as everything else they could do, so they were helping more patients in their eyes by not engaging with me as much as I would have liked. And insurance can be very difficult to understand, and a social worker obviously dedicated to that and pre-authorization, finding the beds, all of that really was an enhancement that was vital to our program's growth. I can't imagine how we would do anywhere near the volume that we're doing now without that. How the social worker and the peer engagement specialists work together, has grown organically over the years, and it's, the face of the engagement is the specialist who goes into the room with the patient, and then a conference with the social worker occurs to decide where the treatment would likely take place.
so our social workers, the dedicated ones, they've developed relationships with the community providers, and because of that, when our social worker will call a local substance use treatment facility and make a referral, the provider knows this is a good referral. So assuming there's a bed available and there's no extenuating severe medical or mental health issues that might preclude them from going there, usually they're accepted because the track record is excellent. This is one of Dr. Horton's favorite pictures. He likes to call it the rope bridge, and he said going from the hospital back into the community, it can be scary, it can be difficult, it can be challenging, and as you can see from this bridge, you could slip through the slots, you might fall over the edge, and that's why we came up with a community-based model. So we found that there was a need for a warm handoff to the community providers upon discharge, and we came up with the Project Engage Community Engagement Specialist in order to help with patients who are coming out of the hospital. Because early on, sometimes this is the first time in a long time they've been somewhat clean and sober, and it can be really overwhelming to try to navigate the system as far as making it to appointments. Maybe they lost their license because of the DUI. They have so many things on their plate. They have undertreated mental health issues, undertreated medical issues. They have legal issues. They've been thrown out of their house. They're looking for a place to live. This is where the community engagement specialist can provide that assistance early on, with the goal being to help the person stand on his or her own 2 feet. But it's sometimes, not always, but sometimes unrealistic to expect a person to, brand new into recovery, to figure out all those aspects. So the community specialist does a really good job that way. The other thing we realized was the need to address women who are pregnant and have an opioid use disorder. So a maternal engagement specialist position was added, and this person works with people who referred to her or referred to the program, or our ED specialist might go down and see a pregnant person, come back and tell the maternal engagement specialist, oh, you need to go down to the ED and see this person. I remember myself in the maternal engagement specialist went down to see this lady who was pregnant, and she stayed overnight. We got her between working with the social worker in a local place that would take pregnant women. She ended up going there, and now she's doing well, because otherwise she may have just left and who knows what would have happened. So based on the success of Project Engage, where it's well known in the community and beyond, the construction industry contacted Dr. Terry Horton and requested Project Engage. So the leadership team began meeting with some of the key construction people in Wilmington, and since then, over 20 construction companies have participated in funding an engagement specialist. This is, at this moment in time, standalone funding for the engagement specialist, who, two things. One, he has a background in construction, so he speaks the language, he understands construction workers, understands the challenges, putting aside substance use disorders, just how they think, how they act. And he's also in recovery from substance use disorders. So what he's just beginning to do, because this is a new program, is working with the employees and with the families of the employees. And we're putting together, we're finalizing, the referral process. Our one social worker is intimately involved with it, working with the HR departments, getting the insurance information, so that when someone raises their hand and says, I need help, we're able to be there, right there for the person. This is case number one. It's a success story, and this is an example of how and why Project Engage is successful.
This patient was a 52-year-old male. He had a long 43-year history of continuous chronic alcohol use. He never really had any length of sobriety other than maybe being hospitalized. Typically, he would use about 6 24-ounce beers, maybe a half pint or more of vodka a day. He had been seen many times by Project Engage, by myself. There were many times that I couldn't see him because his cognitive presentation was so blunted, or he was having some kind of mental health crisis. So many times he came in, we couldn't engage him. But in spring of 2015, again during an admission, we were able to meet, and we continued our relationship that had been going on for a couple of years at that point. He was willing to get help. He just was so cloudy that I couldn't get a phone interview completed with him for one of the rehabs. I didn't even try. I could see that it wouldn't work. We hoped with a continuing stay in the hospital he would clear up to the degree that we could. The social worker actually presented him to various treatment centers just to see if they could hold a bed until he was able, and so on. And one of the treatment centers actually knew him because he had prior treatment experience there, and they thought that he was too far progressed into alcoholic dementia and wouldn't be able to participate in his own treatment. So they said, even if he does clear up, to the extent that he could do a phone interview, we're not interested in even taking him. The attending physician referred him to the psychiatric department. He was eventually put on the psychiatric unit to stabilize. And the hope was that he would become more cognitively able to participate in treatment, and perhaps we could move him along to more intensive substance use treatment. But he was eventually turned down by every place that was covered by his insurance.
But he eventually was able to do some outpatient treatment, and that's when he was still in the psychiatric floor, and he went there willingly. He wasn't committed. Peter had talked with him and said, look, maybe this would be a good place for you to be, just to get stabilized on your meds, because what would happen is he would drink so much he'd forget that he had an appointment with his psychiatrist. So more often than not, he was off his medication. So it wasn't that he was a threat to himself, it's just that he was not stable on the psychotropic meds. Once he got stable on the psychotropic meds, he became a lot more lucid. Our community engagement specialists went in, met with him, got him enrolled in the program, and the 10 months prior to hooking up with our Project Engage community engagement specialist, or if you want to call it the community program, in the spring of 2015, he had 2 inpatient and 11 ED episodes. The 10 months following working with the specialist, there were no alcohol-related hospital visits. He actually only had 1 ED visit, and that was due to a prescription medication interaction. So what happened is he was able to break his 43-year cycle of drinking. His personal care and social support improved. And this is kind of cute when the community engagement specialist, who happens to be a female, would go to pick him up. He'd say, "Did you notice? I shaved and I put on cologne. I wanted to make you happy." You know, and he wasn't at all trying to, you know, pick her up or anything like that, but he was so excited that he could actually function like a human being without the use of alcohol. He had diabetes, he had hypertension, and both of them prior were not well controlled because he'd forget to take his insulin, he'd forget to take his hypertension medication. Once he became sober, he started taking them, his legal issues were resolved, and what was really cool, he was reunified. His family wanted nothing to do with him because they never knew behind door number 1, door number 2, door number 3. What are we going to get when he shows up? And so he wasn't welcome to any of their homes because more often than not, he'd show up under the influence. And he actually got to see his grandchild for the first time. So this is just an example of how the interdisciplinary health care team collaborated, worked together to bring about a positive outcome. And this included Peter, who saw him in the ED. Peter saw him inpatient, the dedicated social worker, the community engagement specialist, his PCP, who was absolutely shocked at how well he was doing, because half the time he wouldn't show up for his appointments prior because he'd forget. And also his mental health provider was thrilled that he was showing up and was compliant with his medications. So if you want to read the whole story, it was published in the Delaware Medical Journal, and it is going to be posted to the webinar library. So if you want to read the whole article, that would be great. So before we move on, at this point, are there any questions up until now? Hey, Crystal, do you know if there are any questions?
Crystal, this is Jean. I don't know if you're muted. I do see some questions here, but we wanted to defer to you first. If you're on, we can't hear you.
Well, Jean, if you have the questions, go ahead.
Okay, so let's see. They're really hard for me to read on here. This is kind of a hard question. How is this different from case management? There's one question for you.
Okay, that's a very good question. And I think what makes this program, or programs like this, unique is the people who work in it are in recovery from substance use disorders. So it's not just a case management, it's also providing support, being understanding, being empathetic, and realizing that it's not so much that people fail treatment, treatment fails people. So it's connecting the dots. So it's a unified approach using the dedicated social worker and the engagement specialist to work with the patient.
The main function that we do have is to meet the patients in the hospital setting, whether it's their PCP appointment or inpatient or emergency room, what have you, and assess their motivation to change their substance use. Become consultants to them as they go down the road. we're not actually, other than the community specialist, we don't see them outside of the hospital. We may talk to them on the phone from time to time. They may come in again and we'll work with them. But I think our main purpose is sort of an expert type arrangement. RT. Really the RT part.
Yeah, you know, I guess what I thought was really smart about the way you presented the information so far is that it really seemed like the roles between and among the interdisciplinary team sort of evolved, but there was a level of trust that enabled you to make sure the focus on the individual trying to get into recovery really remained consistent, and that was really what sort of led to the additional phases and why the program has been so successful. Would that be overstating it, or does that sound right?
That's an excellent point, Jean, because what we encourage all the engagement specialists to do is when they go on the floor to meet with the nurse, talk to the doctor, hey, I'm going to go see Mr. Jones, and furthermore, once the person gets into treatment, to go back and share with the team, do you remember Mr. Jones and how rough he was having it here? Guess what? He hasn't picked up a drink or he hasn't had a drug in 2 months, 3 months, 4 months. That really excites everyone because they're like, wow, this really works. We're able to actually help people. Because as we said earlier, staff morale sometimes when you just see, you know, the same person or the same person coming in with similar drug use, it can be kind of demoralizing. So we try to, good news, so to speak.
Yeah, yeah. There's a couple of other questions on here. Let me give you the next one, which I also really appreciate. How do peers manage their own wellness on the job?
Well, a lot of what we do is really similar. For those of us who are in 12-step recovery, a lot of what we do is real similar to 12-step work with regard to actually going to see someone who was similarly situated as we were in the past, go see them and see what we can do to help them. So in that way, it's very enriching. And also, I've been doing this for 5 years. I've never once seen a patient in the condition that I see them in and think to myself, boy, that looks good. I don't think I want a piece of that. My recovery is reinforced every day. But we have to learn boundaries, and we have to learn limits. And even with our disclosure, some days we're going to be able to disclose more, and some days we're not going to be comfortable with that. And in certain situations, it's called for, and it's not. And that's another way that we manage our wellness, is that we're kind of in control of our own stories. It's not just, we're not just splayed open every day, you know, to do this job. We also have to be very careful to manage our recoveries, however we've come to recovery outside of the job. And we've had to learn things that all clinicians have to learn, how to let go of, you know, the daily struggle, how to, you know, be present for the patient when you're here, and then be present for your friends and family when you leave. And all these things are learned on the job, plus we've had great supervision and training.
Okay, that's great. Another really good question. These questions are excellent. I love this next one because I think it really speaks to the specific goal of this webinar, which is that we want to enable those on the call to start their own programs and to have talking points for their leadership teams to get these types of programs started. So the question is, how does Project Engage measure outcomes?
Well, we have a computer program that we input our information so we can run reports as far as the number of people that came in. And also we do keep track of the outcomes as far as were they referred to outpatient, inpatient. We have the patient sign a release so that our administrative assistant can call to verify did they show up, how are they doing. So at any given time we can generate a report for leadership just to show them the effectiveness of what's being accomplished.
Okay.
Plus, I would say another thing just real quick is the importance of having leadership on board. Like our president and CEO is well aware of Project Engage, a lot of that through the efforts of Dr. Terry Horton. She's a real champion of Project Engage. It didn't happen overnight, but and also all the interdisciplinary healthcare team, they didn't just one day not be interested and the next day interested, but it was a matter of letting them know what we do, how we do it, and the outcomes for the patient. So they have the buy-in. It's just a natural buy-in.
Yeah. So the next question.
This is triggered by the interdisciplinary team satisfaction in our work, regardless of the outcome. Most of the time, when you talk to someone on the team, they'll say they don't remember how they handled it without us, which is a great compliment. A lot of us have been awarded things like being the star of the month on a floor, which is usually reserved for a hospital employee, not an outside person. But they value us regardless of what the outcomes are, but many of the people don't know yet how successful we are.
Yeah, and I think the other point here is that there is a consistent publication step that you all take there that others can avail themselves of the publications to learn a little bit more about the specifics of the evaluation. But that parts of the program are still evolving, so the evaluation is sort of ongoing. Would that be accurate?
Correct.
Okay, great. Now here's a question that came in early on, and I apologize that I did not do these in order, but this is for both you, Mark, and you, Peter. Are you certified as peer support specialists or peer recovery specialists in the hospital? Do you work with a specific case manager that comes in and facilitates the treatment for the individual after the engagement specialist has met with them? So I think there's a little confusion about are you the engagement specialist or are you one of those other titles? And because that we call peers different things in different parts of the country, it's important to clarify this point. Let me know if you want me to read it again.
No, I think we got it. Like, from ESPR, we do primarily the IRT. We do intervention because they've already come into the hospital. They've had a CWA protocol done. They may have had a COWS done. They've had some kind of the audit done. So when we get called, we know that they're there for a substance use disorder. So we don't have to screen to figure out do they have one or not. So we're doing the referral to treatment. We're not a treatment program. We just get people referred out to programs. So what the engagement specialists, they all, in hopefully a short period of time, become a certified peer recovery specialist.
Okay.
And then I'm a program manager, so I oversee them and provide them with supervision.
Okay, another question is, as far as now, so I don't know if this is more of a question or a comment, but I do want to acknowledge all ideas in the question box because I think that others will appreciate it. As far as further education for CPRS, don't they already have a doctorate degree from a university of the streets?
Well, yes, because we talked about being experientially credentialed. We don't require people to further their education. We encourage them if they so want to, just because we believe, every person, if they want to further their education, they should be able to do that. Having been in addiction doesn't preclude you from becoming more knowledgeable of things.
I came to this job while I was doing an associate's degree in drug and alcohol counseling, and I was interning at Brandywine Counseling. So I had my own addiction history. I was studying drug and alcohol treatment. I actually am enrolled to finish my bachelor's in psychology, and on Saturday I'm sitting for my CADC exam. and I'm not unusual. Everybody in our program seems to be more on the path of growing and gaining more knowledge.
Okay, I'm going to do one more question, and then I think we need to go back to the rest of the slides. There is another opportunity for questions and answers, so please keep adding your questions to the chat box if you have one, and even if you think we're not going to have time for it because there's too many, put them in there anyway, because we will get the answers and email them to you. This may be kind of a hard question. What is the budget for this program? Are there, oh, and that, well, actually, that question is a standalone question. What is the budget for the program?
Our program director handles, works with behavioral health to develop a budget each year. I know one year, I believe, was around $1 million, but don't quote me on that. And that's a question that actually we can answer after the webinar, because I don't really want to speak out of turn as far as how much it is. We can, I'm sure we can provide that, answer that question.
Okay. Yeah, there's several more questions, but let's keep going, and then I'll start in on the questions where we left off so that those who put them in early get the answers soonest. So let's continue, and we'll get back to the questions in a bit.
Great. All right, here's another key component, and Project Engage. This is actually Dr. Terry Horton saying, he likes to say, we are a concierge service to help patients get what they need. And that's like getting them into treatment, whether it's detox, inpatient, medical care, mental health care, that type of thing.
What we do, like a concierge in a hotel, we get to know our patients. So we build relationships, maybe not just for that one admission, but maybe for the long haul too, on previous or on future admissions. We try to break down whatever barriers or perceived barriers they have. Much like a concierge will point you in the right direction to get a phone charger if you leave it at home. We help the patient define their needs. We help them decide if a problem exists. Maybe all we do is plant a seed that maybe later will grow into, the germ of an idea that they need help. We do a warm handoff to treatment, both literally and figuratively. We'll carry bags, their bags to the van before they go to inpatient treatment and see them off. We get them ready for the outpatient treatment by giving them every opportunity to ask questions. We let them know what's going to happen. If we can, we'll even describe the room they'll sit in, just so that they have as much comfort as they possibly can when they get to where they're going, because we want to give all the aid and comfort we can, because there's a difficult path ahead. We know personally how we just want to make it so that we get them to their first destination so that they can succeed and continue on, and we want to give them the best chance at that as we can. Dr. Horton likes to use the example of a stroke patient. A lot of our patients do have cognitive challenges secondary to their substance use, and he tells us, if you wouldn't, after someone has a stroke and they recover to the degree they do and they leave the hospital, would you tell them where their physical therapy is and hand them a bus ticket for the next day and tell them good luck? And if you wouldn't do that, then why would you do that with our patients? So we take that extra step to hand them off, a warm handoff, the warmest handoff we can give them. Sometimes it might have to be at a distance, but we do everything we can so that they get exactly what it is they need.
Right, and just one quick example. Down at Christiana, I was with one of the engagement specialists. We were talking with a lady who had come in, and she really wanted to go inpatient, but she said, well, my concern is I only wore the clothes that I was brought in with, and I haven't had time to, obviously I haven't put them through the washer and dryer, so I really need to go home and get clothes. And I said, so is that the one major thing that's holding you back from leaving the hospital, going to the treatment facility's van and going right into treatment? She said yes. I said, well, if we can provide you some clothes, because we do have like a clothes closet. And she goes, absolutely. So we got her size, went down, got clothes, brought them back up, and off she went. So we tried to remove as many barriers as possible to allow them to go ahead and go into treatment. So one of the things that Project Engage has done is help address suspected drug use in the hospital. And this came about from the safety committee talking and the legal committee talking about, there's the possibility that people might be using in the hospital. So a pilot was begun to address this. So I did training for the nurses and the techs and the doctors, basically the whole interdisciplinary team, on signs and symptoms of drug use, what to look for, and so they thought that was really helpful. So what they do is, prior to calling us, they'll call a constable to come and do a room search, which makes sense because if we went in first and then a constable came in, that could kind of blow the therapeutic relationship we're trying to develop. So once the room search is determined, either they took it out, or then we'll go in and talk with the person about getting into treatment. But from this pilot came the realization, the need to address opioid withdrawal, because after the trainings that I did, staff would say, well, I feel so much better, I feel more knowledgeable. Now I understand why, Joe kept running in and out of the bathroom. Now I understand why the sheets had to be changed like 5 times on a shift because they were going through withdrawal. And they said, look, right now all we have to offer them for the most part is Imodium and quantity. Can't we give them something else? And that's when Dr. Horton, who is a real champion of helping patients, realized we really need to do something. So that's where we came up with the opioid withdrawal protocol. And we'll talk about that in just a second. But one of the things about opioid withdrawal, it is a safety issue. If it's poorly controlled, patients may self-treat. In other words, they'll have so-called friends bring in drugs, or they'll just leave AMA, which we all know 2 things can happen, or actually more, maybe 3. One, the person may go out, use, and possibly OD and die. Or if they came in with, say, endocarditis, they might go out and use, and that really compromises their heart. And if they do that, they're probably going to come back in, so readmission rates go back up. Additionally, staff may experience concerns because they have what I call grumpy patients, because they're clicking that button because they want more pain meds. It's not so much, they may not really be in pain, they just don't want to be in withdrawal. And also, there's always that increased possibility of needle sticks, because if they're hiding their syringes under the mattress and you go to change the sheet because of it's perspiring so much, you put your hand under, you might get a needle stick.
What we try to impress upon everyone is that the extraordinary behavior of people who are opioid dependent, both in the hospital and in society as a whole, it's not because the high from opioids is so pleasurable, but it's because the withdrawal is so horrible and painful and torturous, they're willing to do anything not to experience it.
So case number 2, we had a 21-year-old present. He came into the ED because he had OD'd. He had endocarditis, along with, he started going into opioid withdrawal. He talked with the engagement specialist, and he said, look, I cannot handle being here. He was supposed to be there for 6 weeks for long-term IV antibiotics to help with his endocarditis. His heart was completely vegetated, and it was kind of 50-50 if he was going to make it, and the odds were really against him if he left AMA. So this was an experienced engagement specialist. He was able to advocate for the patient's needs with the interdisciplinary healthcare team. He didn't tell the team what, tell the doctors what to do. He just said, what can we do to help this person with their withdrawal? Because this was when Suboxone was kind of being used. Sometimes it was, sometimes it wasn't. And so Dr. Horton got involved. got him prescribed Suboxone. He stayed for the 6 weeks, and his girlfriend was pregnant. He, about a month or so ago, stopped by to show everyone the new baby, and he made a point of, he either called or stopped by to tell this engagement specialist he just purchased a home nearby. He's working, he has a home, he's with his girlfriend who was really frustrated, was getting frustrated with him. So very, very successful. So that's how the need for an opioid withdrawal protocol came about. So a leadership team came together, and Dr. Horton and others really spearheaded it, and it's still early on in the rollout phase. Data is still being collected, so it's just going to be exciting to see what comes from that. And staff, I can tell you, are thrilled that this is actually taking place, because there's nothing worse than walking to someone's room who's going through withdrawal and say, hey, here's your Imodium and here's your clonidine, and more often than not, they hear, hey, guess what? I'm walking out. And this way, by keeping them, we help them with if they have medical issues, and we can help get them into treatment, so hopefully lessen their relapse.
Another exciting development with Project Engage was we were given an opportunity to help another healthcare system. A healthcare organization in Pittsburgh was looking at ways to increase initiation into and engagement in treatment for substance use disorders for their patients. They reviewed various models and became very interested in Project Engage, so they contacted Dr. Horton. Dr. Horton asked me to go to Pittsburgh with him, and we presented something similar to this webinar to them for their consideration. They ultimately decided that they would like to model Project Engage for their own initiative. We were able to provide training for them here in Delaware. They sent their peers, supervisor, and a program leadership for 2 days for hands-on training on all the aspects of the program. We, after that, provided monthly teleconferencing technical support and assistance as they grew their program. That piece of it ended over the summer. The program is up and running, still going strong.
So for the sake of time, I have a list of marketing strategies we provided for the Pittsburgh peer navigators to use, as well as we had a very good, robust discussion on barriers of what did Project Engage do to overcome them. So for the sake of time, I'll send these to Jean, and she can post them on the website. So, but again, we did emphasize to them, it's a step-by-step process. It doesn't happen overnight, because during the monthly conference calls we had with the Pittsburgh team, they're like, well, it's just starting. We're like, that's fine. It's going to take a little bit of time. It's great that you want it to happen immediately, but just like with addicts who want what they want, and they want it right now, they wanted it to happen like instantly, and it's grown, it's doing really well. We're going to pretty much end with this, because it's no secret that there's a heroin epidemic, and this is just showing you the number of deaths related to prescription opioids and heroin drug poisoning from 2000 to 2014. Unfortunately, it just keeps going up, and that's just so scary. So one of the things that happened was our local police department, the Newcastle County Police, they approached Dr. Horton. Again, we're known in the community, and they came to Dr. Horton and said, how can we address this need? What can we do? So this is like really early on, but it's just beginning, and what we'll be doing is in the ED developing a protocol for warm handoff. So if Newcastle County Police go to somebody's house, they Narcan the person, revive the person, the ambulance is there, the ambulance transports the person, the charge nurse will be given a heads up, and if there's a ED specialist on site, they can go, and once the person is situated and stabilized, meet with the person to talk about treatment options. So as I said, this is brand new. We're still formulating how this is all going to work, but it's an example of how Project Engage has become well known in the community, and now the community is coming to Project Engage, specifically Dr. Horton, to say, what can you do to help us? Whether it's the construction industry, whether it's Newcastle County Police, whether it's another chain of hospitals out in Pittsburgh, or whether it's this webinar saying, we've heard this works and we want to know about it. So sustainability, everyone wants to know about sustainability. This is one of the things that we're working on. First, obviously brain and white counseling, they were the ones that offered Bobby in the hospital. And then next there was a generous donation to help Project Engage continue. Now that the hospital recognizes the work that we do, we're funded through the hospital for the inpatient ED components. The community programs, Medicaid is being set up to provide the bulk of the funding for those two programs. And then the construction program is funded by, as we said before, the participating construction programs.
As peers, what we do is we do our very best to integrate into the existing systems. So in the hospital, throughout the hospital system, we're considered an essential service, just like physical therapy, respiratory, etc., and getting a referral to us is in the same way that they do that. So that is the best way we possibly can. We fit in like a professional service, like anybody, like any other service in the hospital. That's been key to becoming part of the brick and mortar, as it were, of the hospital. In the construction industry and other industries that we may do in the future, it seems to be a very similar thing. The integration appears to be heading towards like being an EAP service for them, something they're familiar with. And all of this said is that we want more referrals so we can see more patients or clients and help them get through their substance use issues at the time. Everything we do is set up to see more people.
And this is just showing what Project Engage did for Christiana Care Healthcare. This is from September 2011 to May 2012, and it was 6 months before and after engagement. There was a negative change. In other words, there were less inpatient and less ED visits. So it averaged about, annualized about $6,000 per patient cost savings. And then the outcomes, we see about 2,000 patients annually in the inpatient and the ED, and usually we have between 15 and 20 people in the community-based programs, and 25% of the patients are engaged into care, and then 40%, they will receive brief interventions and some education, because some people they're not ready to go into treatment, but they will take information, and sometimes they'll call back and say, hey, you remember me? You gave me that flyer on XYZ treatment facility. So, Peter, what do you have to say about that?
Well, we have a lot of people that we try to plant a seed, as I said before, and you never know where that seed is going to grow. We had a patient where had his girlfriend in the room. We did our normal engagement with the patient, and a couple of weeks later, the patient's significant other called and said, you probably don't remember me, but I was in the room with so-and-so, and I kept your card. So-and-so has kicked me out of the house. I'm living in a tent in the woods now, drinking a quart of vodka a day. Do you think you could help me? Eventually, we got her to come into the emergency department. She was admitted, went through part of her detox here. We were able to move her on into treatment. It just goes to show that if we do our jobs and we show that level of care and empathy, that seed that we plant can grow, and sometimes in very surprising ways. That person called me about a month and a half ago to once again say, you probably don't remember me, and then proceed to tell me that she was celebrating her second-year anniversary without a drink or a drug. And that's what makes it all worth it, and that's why we do this.
So, Jean, more questions?
Yeah, we have some fabulous questions. I love that last story. I love the whole thing, but I love that story. I get chills. I got chills each time I heard it, both yesterday and today. Are there any plans to add parent and family peer support into this program and then in parentheses, experientially credentialed parent/family coaches.
Not right at this time, but we do work closely with a program that was founded by a father and mother who lost their son to a heroin overdose. And there's another gentleman that's active with that program. So they do a lot of, they run, my gosh, there's about 5 parenting groups throughout Pennsylvania and Delaware, where they work with loved ones who have, parents that have loved ones dealing with addiction. So we will refer to that program at this point in time, and we would love to do that, but I think that's down the road.
That might be phase 5. Okay, thank you. Is it a requirement to be a recovering addict for someone to become a peer specialist?
Yes.
Okay.
Because that's how the program's was founded, was to be experientially credentialed. That gives credibility to the people going in to talk to patients.
That's what breaks down that wall between us and the patient so quickly. We can get to that patient's truth much more quickly than if we had to have a general conversation, maybe vet ourselves in some different way to gain their confidence.
Okay, that helps explain it. Next question is, and we still have 7 minutes left, and we're doing these questions rather quickly, so I think we'll be able to cover several more. Do you know what your actual connect rate is of people that you refer? I think that might have been in your slide.
25% at least.
Yeah, at least 25%. Okay, next question. Is there an education requirement, or is the position specifically to offer assistance from an individual who is in recovery? So do you guys have to go to mandatory training and get some kind, take some kind of?
Yeah, we have mandatory training from ATTC. Brain and Mind Counseling has mandatory trainings. It's like for people coming in, they may never have heard of SBIRT, so they do the SBIRT training. They do motivational interviewing training. They do basics of addiction training, just so that they may have been in addiction, but they may not understand, the aspects of on the other side.
We need to have credibility. Our experience gives us credibility with the patient, our substance use, issues, our own substance use issues. But in order to have credibility with the medical and interdisciplinary staff here in the hospital, we have to have knowledge of evidence-based information about addiction, or we're not credible. And if we're not credible and professional, we're not someone they're going to call to help their patients. And so that's kind of like a polishing that we have to do in order to become treated, to become viewed as serious tools they can use in the hospital.
Right, so through ATTC, the Addiction Technology Transfer Center Network, the 2 mandatory trainings that everyone has to take, Foundations of SBIRT and Essential Substance Abuse Skills, Foundation for Working with Addictions, and then Brain and Mind Counseling, who, we partner with Christiana Care. We do ethics, diversity, co-occurring, that type of thing. And then the hospital itself, some of the things we have to do training is on privacy, confidentiality, diversity, and they also have an ethics in infection prevention and direct care training as well. So when you first come in, there's a wide variety of trainings that engagement specialists are required to complete.
So, I think that what this question may be pointing to is, is there a certification required? And I don't think we have time to get into the details, but I will offer to that individual, although I can't really see right here who that is easily. We do have a regional group of peer leaders in Region 3 that are meeting quarterly in person, and they're compiling and comparing what the certification requirements are in each state in Region 3. So if there's something more you'd like to learn about that or get engaged with that, please reach out to me, and I'll be happy to get you involved in that group. Okay, next question, do your engagement specialists also help determine if a patient may have an SUD, or do you always already know a patient has an SUD?
It can happen either way. Our patients are pre-screened in a couple of ways. One, every inpatient in Christiana Care gets a small version of the audit, the alcohol use disorder identification test. It's called the audit PC. It's 5 questions. If they score 5 or more on that test, then they're going to be put on the Clinical Institute withdrawal assessment to make sure that they don't go into alcohol withdrawal, which can happen if we don't know ahead of time. And additionally, if they score on that, they're going to get additional questions about prescription medications. That doesn't always prompt a referral to us, but also the history that the patient themselves gives to the medical team may trigger them to ask the patient if they want to talk to somebody about it, and then we'll be called. But yes, it does happen that many times we come in and the true nature and extent of what they're doing is not known until we speak to them. So we'll flesh out the depth and breadth of whatever it is that's going on, where only, a thumbnail is known when we walk in.
Okay, I'm going to let Crystal Downey from the Screening and Brief Intervention Referral to Treatment National SAMHSA-funded Addiction Technology Transfer Center take the rest of those questions, give them to the two of you so that you can answer them and they'll be sent out. I do want to make some wrap-up comments. And I also want to put a teaser out there to Crystal and everyone. When you talked about the model of the Pittsburgh team coming down to Christiana for 2 days to be trained, the teaser is, or the idea is, maybe there's people on this call that would like to become a part of it sounds like a Train the Trainer or a Project Engage orientation project, and so maybe that would be a follow-up positive outcome from this webinar. Community, at your institution, in your state, you need a champion. You need with a top-down, bottom-up support for the principles of the program. It's very important to treat each individual with respect and meet them where they are. Data and publishing are key, and there are lots of steps to the process, so you need to be patient and reach out for help when needed. So what do you think about that summary? Did I miss anything?
No, that was excellent.
Okay, good. Well, I have to do some thank yous here. There's so many. This is a 3-part series. We had 6 speakers that put all kinds of work into preparing slides and then practicing and making sure the webinars all went smoothly. So I just wanted to mention that. Also, the Addiction Technology Transfer Center, Crystal Downey in particular, and Dr. Hagel, with whom I've worked for years, they are just stellar. Everything they touch turns to gold. But most of all, I want to thank each of the individuals that have been on all of the webinars, hoping not just to reach the people on today, but those who listen to the archives and have been on the prior webinars. If it weren't for your interest, our goal of helping spread the word of a series of programs that work, that have been requested by people like you through the sort of regional collaboration, that really applies to everyone all across the country. If it weren't for the people in the audience, there wouldn't be any point in doing this. So Crystal, I think I didn't give you time to say what you needed to say at the end, so I'll be quiet now. Thank you.